firmly standing as the cultural vanguard of West Java, Indonesia, nourishing the intellectual life of the nation, working for the benefit of the global world. This is Universitas Padjadjaran. Inspired by the vision of the Asia-Africa Conference, attended by representatives of 24 countries, the establishment of the university was the realization of the vision of the cultural figures of West Java to found an institution of higher learning in the cosmopolitan city, to educate and set forth to society dedicated and qualified individuals. Today, UNPAD has broadened its wings to encompass various disciplines and multidisciplinary academic endeavors through the efforts of 16 faculties and 1 postgraduate school. To achieve its mission to build the capacity to adapt and innovate in the face of the rapid development of science and technology at the international level, UNPAD is determined to become the center of research and innovation for the good of the nation and the world by continuously nourishing research and developing technology to create innovations in various disciplines. Currently, 36,000 students are registered at UNPAD, and more than 200 international students are registered in different programs, degree and non-degree. As an effort to constantly improve the quality of education, Universitas Padjadjaran is supported by approximately 2,100 professional faculty members with reputable qualifications. To achieve the goals of its mission, UNPAD has also established notable research centers, which demonstrate serious commitment to and focus on achievements in a number of strategic fields, such as the Center for Sustainable Development Goal Studies, the Center for Environmental and Sustainability Sciences, the Academic Health System, the Center for the Digitalization and Development of Sundanese Culture, the Center for Innovation and Pharmaceutical Services, the Center for Nanotechnology and Graphene Research, to name a few. Equipped with a central science laboratory network and a science and technology complex in the Center for the Development of Science and Technology on the main campus, Universitas Padjadjaran has risen in its role as a leader in higher learning geared towards innovation. UNPAD also fosters collaboration with other institutions involving all stakeholders.
Universitas Padjadjaran commits in providing benefit and service for the good of humanity and the preservation of the environment. This is a great enterprise which cannot be done alone. UNPAD believes that in the spirit of collaboration, this vision may be achieved. We invite you who have the same vision, a good intention to care for human life and the environment all over the world, to work with us, build collaborations, create a better world together.
Universitas Padjadjaran grew out of the community and has made it its duty to give back not only in the form of the dissemination of knowledge and information, but also through socially responsible activities such as student fieldwork, community outreach programs, and action research seeking to make direct impact on the community. With its feet firmly grounded in the local communities and environment, UNPAD is also making great efforts to take steps towards internationalization. It offers special programs for international students to maintain its global network and make its strategic and reputable place on the world map of higher education. As a site for the personal development of young minds and bodies, UNPAD supports a wide variety of student activities. UNPAD also provides students with libraries with an extensive collection of books, periodicals, and study materials, comfortable dormitories, health and fitness services, free on-campus transportation, and other supporting facilities which UNPAD continuously upgrades and improves. While being committed internationally recognized quality research, UNPAD maintains also its dedication in preserving traditional cultures as the compass for all of UNPAD's activities on and off campus. As of now, UNPAD have set forth unto society 200,000 graduates in various fields of work, including strategic government sectors and crucial multinational industries. Works for the good of society, bringing innovations and sincere contributions to humanity. Universitas Pajajaran, the pride of West Java, working for the benefit of the global world.
Greetings from Transcendent 2021, massive open online course in Cleft and Palette held by Faculty of Dentistry Universitas Pajajaran, collaborating with Smile Train and Indonesian Cleft Center that has been going on for a few weeks now. My name is Rashid Abdulaziz. I'm a dental student from Faculty of Dentistry Universitas Pajajaran, and I see that we all come from around the world, so I think it is appropriate to say good morning, good afternoon, and good evening to all of us. Earlier this week, we have discussed about the challenges of cleft surgeries in COVID-19 pandemic. And on the previous week, we were discussing about the cleft anesthesia and the alveolar bone graft in cleft patients. And today, we are going to discuss about orthognathic surgery with another amazing speaker. We are so lucky to have him again because on the previous occasion, we had the opportunities to have him also as our speaker on week 3 regarding cleft palate repair or palatoplasty. Greetings to Dr. Syed Altaf Hussain, Senior Plastic Surgeon Consultant from Sri Ramachandra University Hospital, India. Hello, Dr. Altaf. How are you?
Sorry, yeah. Thank you very much for the nice introduction, and I'm pleased to be here. I'm happy to answer any questions, and we can get on. And good morning and good evening and everything to everybody.
Thank you so much, Dr. Altaf. It's been a wonderful opportunity to have you here again for the second time. And thank you for giving your time. Hope you are doing well and stay healthy. And also greetings to Dr. Wisnu, Dr. Vijaya Kumar that attend this live discussion also. And we also have Dr. Anggun from Universitas Pajajaran as our moderator. Thank you so much, Dr. Anggun, for being here.
Okay, thank you so much for having me.
Yes, thank you so much, Doctor. Greetings to all of the participants. Thank you for participating in this course and thank you for attending this live discussion session. So today's live discussion will be separated into 2 sessions. In the first session, Dr. Altaf will be answering the questions that have been filled out by the participants in the MOOC website. And the question will be presented later on the screen. They have already watched the lecture video on orthognathic surgery about the relating topics. So, I think not everyone can make it into this live discussion, but The recorded version of this live discussion will be posted on our MOC website, so the other participants can watch it later. And then in the second session, the participants will have the opportunity to ask directly to Dr. Altaf through comment section or directly by opening their microphone and video. And then the student committees will have to provide the question on the screen. So maybe we could start the live discussion. I would like to give the spotlight to Dr. Anggun as our moderator and Dr. Altaf as our speakers. Dr. Anggun, we can move to the first session. You can lead today's live discussion. Thank you so much.
Okay, thank you very much, Rasid. As mentioned before, my name is Anggun Rafisa, and I will be the moderator that guide throughout this live discussion. Okay, can we start the first session, Dr. Altaf?
Yes, please.
Okay, please share the question. Okay. For the first question is, how long usually will the recovery take after the orthognathic surgery? In what kind of cases the patient needs longer recovery time? Okay, please, Dr. Altaf.
Yeah, well, when you say recovery, I'll give you some aspects of it, because recovery is a very broad question. It's a good question though. So let me put it this way: if I do orthognathic surgery, it depends on how much. See, there are two sides to an orthognathic. I mean, when I presented, on the midface entirely, which includes orthognathic surgery and distraction osteogenesis. Orthognathic surgery, by orthognathic surgery, we mean that we do the osteotomies to the maxilla or mandible or whatever part you want to do, move it to the new position, which is predetermined, and then we fix it. If that, I mean, that refers to orthognathic surgery, whereas distraction, we make the osteotomies, we don't fix them, and we slowly move them. Instead of pulling them and putting in the new position, we slowly move them. That takes much longer. So if you're doing orthognathic surgery, which usually I confine to adults, because growing skeleton, it's not a good idea to put plates and screws. In these patients, shall I say, once we do everything, we send the patient home very likely the next day, unless there is a major problem. But the patient will have to be careful. They need to have soft feet and stuff like that. Make sure that they don't fall down, and because the strength takes a long time to come back. For them to gain about 70% normal strength, it take up to 3 to 6 months, and 100% up to a year. So 70 to 80% normal strength is acceptable, and most people should recover that in about 3 months. But they can start day-to-day activity within 2 to 3 days of the surgery, provided they are careful. They don't bite something very hard and stuff like that. If it is soft, not terribly soft, you don't need pureed food, just softer food. It's practically 1 or 2 days. And for the swelling to go down, maybe 70% swelling goes down. It depends on how you do the operation. If you do it very, very carefully, like we take all precautions to make sure that the tissues are handled very gently and stuff like that. The swelling takes about 3 to 4 days to settle down, max a week, to about 70%. But 100%, it takes a few more, maybe a few weeks, 3 to 4 weeks. But practically the patient can be back to work and usual activity in a couple of days, in a 2 to 3 days. And what kind of patients need a longer recovery time? It also depends. It depends on the patient and the operation. Some people are a little more resilient. They just get on with things. Others are worried and stuff like. In case God forbid, there's an infection, or it took a lot of not very gentle handling during the operation, then it can prolong. And one major problem that happens during orthognathic surgery is rare but possible is bleeding, in which case it can happen during the operation, or it can happen later. Later is very, very rare, fortunately. But during the operation, it can be a little bit troublesome, in which case the patient feels weak and maybe take a few more days to recover. Does that answer your question?
Okay, I forgot to mention before is the question from Raisa Aurelia. Is there Raisa Aurelia today?
Can you repeat that again, please?
Okay, and I forgot to mention that these questions came from Raisa Aurelia. The participant names was Raisa Amelia.
All right. Okay. Brilliant.
Okay.
Does Raisa can she answer? Can she find out? I mean, can let us know that if the question is all right, or is she offline? Maybe she's offline.
Maybe Raisa. Is Raisa present today, or I think she's not here today.
All right. Okay.
Oh, it's...
Thank
So
you,
hopefully that answers her question.
Okay. Thank you, doctor.
Okay. So if I can conclude that, the first question, please. The first question, please. Can you go back to the first question? Okay. Doctor, if I can conclude that the patient that needs longer recovery time is really depend on the patient and the operation, right? The complication and also the instruction post-surgery, the age, right, doctor?
Absolutely, yes.
Okay, thank you. I think it's very, very clear. So we can continue to the second question. It's from Hasna Faza. Is there any significant long-term effect difference between distraction osteogenesis and orthognathic surgery? Please, doctor.
Yeah. Well, we have very, very distinct indications for orthognathic surgery and distraction osteogenesis in cleft patients. We have a chapter in the journal of, in the textbook of plastic surgery edited by Karun Agarwal. It's an Indian publication. It's a 7-volume publication. It has a lot of material in it, which we have written on the midface, which includes both distraction osteogenesis and orthognathic surgery. Now, I would confine orthognathic surgery to adult patients, whereas distraction I would do both in adult certain adult and all younger people, children who have not completed their growth. So when you say long-term differences, there are two kinds of, I presume you're talking about the outcome. You're talking about whether there is any relapse and whether there is stability. So if you take out the growth factor, see, growth can be a factor that causes a bit of confusion there. So if you take out growth, for instance, if you compare both adults who comparable adult who underwent distraction osteogenesis and another adult who went orthognathic surgery, the difference is not much at all, except in when you do distraction osteogenesis, there is certain amount of relapse which you need to anticipate. So I always distract about 10 to 20% more. Again, we have a chapter on the textbook of cleft and craniofacial surgery by Berkowitz. So we have actually done a study on how much relapse is expected. We find that it's about 20%, about 20%. This is in spite of all the the precautions you take. You need to take make all efforts to prevent relapse. What we do is we, even after the distraction is complete, which takes about 2 to 3 weeks, we retain the distractor for a further 3 months, and then we remove the distractor and replace it with retention devices, removable retention devices up to a year, sometimes longer. So in spite of all that, there is about 20% relapse. So in the past, distraction has been discredited because of its relapse rate. But if you take adequate precautions, it's an excellent way of achieving making the patient look normal again. Because in cleft you don't get the phenotypic face is not the same as what the patient would have grown into. His or her genotypic face would have been a little bit different. And our aim in these operations is to restore the genetic potential, which we can achieve by both methods. Only thing is you need to take precautions. Even in orthognathic surgery, there is some amount of relapse which you expect, but again, you need to factor overcorrection a little bit. But it need not be 20%, but it could be, say, 5 to 10%.
Okay, doctor. Is Hasna Faza here in the Zoom today? I think she is not in Zoom also, doctor. So can we continue to the
Yes,
next
please.
question?
Yeah.
Okay, for the third question is from Josefinda Ayu. Is there any methods to relieve any pain in the jaw after the orthognathic surgery?
Yeah, just regular pain relief. We usually give paracetamol, high dose paracetamol, about 650 to 1 gram 3 times a day. That's good enough for pain relief.
So paracetamol is enough, right, doctor?
Absolutely.
Okay, thank you very much.
Provided you've done your operation well.
Okay. Okay, so the next question is, in the lecture, it is said that mid-phase hypoplasia is an inevitable result of cleft surgery. What differs is only the severity that varies. Is there any factors that contribute in the severity of mid-phase hypoplasia after cleft repair? What can we do to minimize the degree of severity? Please, doctor.
Yeah. So number 1 is patient factors, and number 2 is the factors related to the surgery. So we can't control patient factors basically. So the patient factors are, some people may be more prone to class 3 malocclusion. So they may have a genetic potential, number 1. Number 2 is the wider the cleft, the more likely, because when we bring stuff together, when we bring soft tissue together, there is more pressure on the bones. So the wider the cleft, the more likely the patient may have problems with the midface. Then we come to the surgical aspects. You need to time your surgery well. If you do too early, you can cause damage. If you do your operation without finesse, if you're not really gentle with the tissues and you do the minimum possible and you don't plan well, then again you have a problem. So you just need to take all these precautions. You do your select your operations, time your surgery, do your operation gently, and then you hopefully will minimize. But much of it is, I mean, these are only things that can influence the growth disturbance. There is no guarantee that there won't be any growth disturbance anyway.
But still, the surgeon plays a very big role.
Absolutely.
to
Yes.
minimize this
Yes.
severity.
Yes.
Okay.
That's why, and all my pictures, there is a long term. If you saw my pictures, there is pre-op, per-op, immediate post-op, 1 year and longer, sometimes 4 or 5 years. So we need to see how the patient progresses to know that if you're doing right or wrong, and then you may need to tweak your operation to suit to minimize problems.
Okay. Thank you very much, Doctor. Can we continue to the next question?
Yes, please.
It's from Shifa Biandra. What is the most challenging case of orthognathic surgery that you have faced? Maybe you can tell us how many cases you have been worked on, Doctor?
We have, see, every case is a challenge. We have cleft orthognathic wise, cleft orthognathic and distraction wise, we have about 350 more cases which you have done. The technically, I mean, if you have many more than one one osteotomy, if there are several osteotomies involved, sometimes it's my orthodontic colleague who plans these operations. He tells me what, I mean, I'm mostly a technician. He tells me how much movement he wants of the mandible, how much movement he wants of the maxilla. He tells me whether it needs a cant correction, it needs a rotation, whether I should trim bone or add bone, all sorts of things he tells me. So sometimes he gives me a very long formula: move the maxilla 3 millimeters, correct the cant by removing a wedge on 3 millimeters on the left side and add 3 millimeters to the right, and rotate the maxilla. But he also gives me a splint to work with. He gives me the roadmap. So when there are multiple things, it becomes more challenging. And sometimes, if you see some of this, some of these operations and osteotomies are done blind. You don't have access to the what is the structure behind, because you know that the patient, you have to know your anatomy to know what is underneath your cutting instrument. Sometimes patients don't read anatomy, so you may cause damage to a blood vessel or something like that, in which case it becomes difficult. I have had 2 cases where there was a lot of bleeding, and luckily we could arrest, the other one was stopped by interventional radiologists. They could identify the leaking vessel and plug it. What we couldn't do in an hour or 2, they could do in 3 to 4 minutes. So they can cannulate the vessel, identify the leaking vessel, and stop it. So it's best to have a backup in a situation like this.
Okay, thank you, Dr. Altaf. Do we have another question from the MOC? Or is this the last? I think this is the last question, right?
Yes.
Okay.
Yeah.
Yes, I think
Yeah, that's very simple. Again, if you don't have a genetic predisposition for a maxillary retrusion, the reason is scarring. Fibrosis. Scar is basically collagen, and it doesn't grow at the same speed as the rest of the child's face. So it restricts growth of the bone. It kind of, it's basically scarring. The answer to that question is scar prevents the maxilla from growing normally.
Okay, it's the scars, right, Doctor? Okay.
That's correct. Yeah.
Okay. Wait. Okay. Is there any questions? Can we go to the next questions? Okay. I think that's the last questions. Last question.
Yes, Doc. I think we can move to the second session where the participants can ask directly to Dr. Altaf. So to the participants that want to ask the question, can fill the comment section, or you can take the opportunities to ask directly by opening your microphone and video. Okay, I think there are no more questions from the participants. So we have reached the end of today's live discussion. It was a very great opportunity to hear the valuable knowledge from Dr. Altaf Hussain. Okay, I'm sorry, I think there is another question from the participants through the comment section from Dr. Andrew Lauren. Are there any differences in performing orthognathic surgery in cleft patient with calcareal bone graft? Dr. Altaf, you
Can we
can
see
answer
that
the
question?
question.
Can I see that question again, please?
Okay.
Can
The
can I
student,
can the question came on the screen? Can that come back on the screen, please?
okay. Student committees, please. Can you share the screen to present the question?
Or Dr. Laurent can ask the question again.
Or Dr. Lauren maybe can open mic to ask directly to Dr. Alf.
Are there any differences in?
I think Dr. Yes.
Yeah. Okay. I understand the question is whether alveolar bone grafting makes a difference to the way you perform surgery. Is that the question? Is that what it means? Can Dr. Laurent open open his mic and speak?
Yes, doctor.
Yeah, is that the question you're asking?
Yeah. Actually, my question is the cleft patient with the ABG procedure. Are there any differences to performing the orthognathic surgery, or maybe
Okay.
the maxillary advancement?
All right. Okay. Okay. So I 90% of my patients whom I take for orthognathic surgery or distraction have had alveolar bone graft. I try not to take them without alveolar bone graft. In the past, I've done, if there is a gross discrepancy between the lesser and greater segments or something like that, then I have also done it without alveolar bone grafting. Basically, it's much easier to handle when the segment is in one piece. It's much easier to handle when the patient has had an alveolar bone graft. But it can be done without that as well. It takes a little more. It's a little more tricky, and the orthodontist should factor all that when he makes the splint for me. When they make the plan, he gives me a roadmap. He gives me a splint to place the teeth. Otherwise, they'll be off occlusion. So in those cases, he needs to keep that in mind. He or she needs to factor in that the maxilla may be in 2 or 3 segments. It's doable. I mean, it's technically a little bit different, but both are perfectly all right. But I prefer patients who have had their ABG and with sufficient bone.
Okay, thank you very much for the explanation, Dr. Hussain.
Thank you.
Okay, thank you very much for Dr. Andrew for the questions. I hope that all the question can be is answered satisfied with the answer of the question. Okay, Dr. Altaf, I think there are no more questions. Is there anything you want to add or mention about this today live discussion?
I think it was wonderful. I think the questions were spot on, and I hope we continue this interaction, and someday we hope to take this forward. I understand that there is a new Cleft Center in Bandung, and I hope I wish it all the best, and I hope to see the best of work coming out from there. And any help I can do to take this forward, I'm more than happy to do so.
Okay, thank you very much, Dr. Altaf, for a very informative discussion today. And I hope we can see each other again in the next live discussion or seminar. Okay, I give back this discussion to the MC, Rashid. Thank you.
Thank you so much, Dr. Anggun. Thank you so much, Dr. Altaf. We are so lucky to have you for the second time. And thank you for your amazing lectures. Thank you for the amazing explanation. I believe that this would be an inspiration to all of us as students, as doctors, as the attendings, to learn cleft lip and palate more and more, even further to implement the best treatments to our cleft patients. Maybe before we ended today's live discussion, can we take a picture first, Dr. Altaf and all of the participants? Please turn on your camera first. Okay, are we ready? The students committee, please help to take the picture. I will count from 1 to 3. 1, 2, 3. Once again, 1, 2, 3. Okay. Thank you so much, Dr. Altaf. Thank you so much, Dr. Anggun, and thank you so much to all of the participants. Goodbye and stay healthy, everyone.